in that perspective. So when we talk about acid-base balance, we need to understand that we've got the proton and the bicarbonate, and there is a carbonic anhydrase which is converting there is the exchange from CO2 and water. These two are produced on that. So there is a common way in which you can think of carbon dioxide is a surrogate way of excreting bicarbonate. So that will be the other thing from that regards. So we have got two major organs. We've got the lungs, which is responsible for the exchange of carbon dioxide, which is one form of acid in that perspective. And then the kidneys, which are basically excreting the proton in the other end of extreme. So these two will compensate to each other. So if you have respiratory acidosis, you will be losing bicarbonate. If you have metabolic, you will be retaining bicarbonate, so your bicarbonate will go up. If you have metabolic acidosis, you will be losing carbon dioxide. So what is the normal response to a metabolic acidosis? How much should the CO2 be? Yeah. 1.5 bicarbonate plus B plus minus 3. Yeah. So if you have a bicarbonate of 10, then you can say, okay, 1.5 plus 8, somewhere around 23 should be your CO2. Now, is this compensation more for an acute or a chronic condition? So if you are chronic, you will have more compensation, which is going to happen from that regards. What about the opposite? If you have a respiratory acidosis, what do you expect the bicarb to be? How much will increase? And for chronic and for acute. So how much will the bicarb increase? So for every 10 millimeter mercury, so 2 and 4 depending upon the chronicity on that. If you have a chronic one, your bicarb will increase both. So there are two organs basically which are going to regulate your acid status. So if you have a problem in one, you may not have that much issue. But if both your kidneys and lungs are going, you are not able to excrete CO2, you're not able to excrete proton, you will have severe acidosis which is going to happen from that regards. Now, bicarbonate is also excreted via the kidneys, but large amount of bicarbonate is resorbed again. More than 99% of it may be resolved from that regards. Another player which does not play a role in terms of regulation, but in terms of the overall process is of course the intestine, wherein we have excretion of bicarbonate. Now, in the intestine or the gastrointestinal tract, we have differentiation in terms of which part of the body secretes which component. So if you have an upper gastrointestinal tract, the secretion there will be rich in acid. So if you have more vomiting, you will have more of an alkalotic presentation. While the lower gastrointestinal tract, the secretions are rich in terms of the bicarbonate. And therefore, you will have acidosis as part of the lower gastrointestinal loss or in the form of gastroenteritis in that regards. So now if we summarize the acid-base balance, we basically see we have got a respiratory component. So you will have acidosis if your CO2 is going up and the lung is not really ventilating from that perspective. Or you can have a problem or metabolic acidosis wherein you have a problem either in terms of accumulation of acid, decrease excretion of acid, or increase excretion of bicarbonate from that regard. So you have new acid which is being formed. The classical example in our setting will be diabetic ketoacidosis, or you can have an organic acidemia. These conditions you will have a high anion gap. So what is happening is that you've got a negative ion which is getting accumulated. So that's a high anion gap scenario. And the other scenarios could be in which you have got either a loss of bicarbonate or less loss of proton. You will have a normal anion gap or a hyperchloremic metabolic acidosis. This is a typical scenario. Now, since we are focusing predominantly on renal tubular acidosis, we'll dwell more about the renal process through which the proton and the bicarbonate ion are handled. So we know that proton is secreted effectively in the DCT. So there is no proton. Proton is a very, very unique thing. And I'll talk about that in a bit later, that proton cannot be going directly through diffusion. You need to really push it through a particular active transport. And this happens only in the distal convoluted tubule. So 1 millimole per kg of proton is excreted per day from the distal convoluted tubule, while bicarbonate is largely filtered unhindered in the proximal tubule. And this is a huge amount, 400 millimoles per day. So you have got a substantial, around 70 times more amount of, so if you talk about this per kg, this will become somewhere around 70 millimoles per kg per day. So like 70 times more amount of bicarbonate which is filtered. But most of this bicarbonate, around 99% will be resorbed. So effectively, you're talking about similar sort of a processes. Now, in this perspective, if you now want to understand the basic difference in terms of proximal or distal RTA, so Dr. Sandeep, which one will be more severe? Why?
The HIM not proton is not secreted, sir. So there is accumulation of proton, and there will be a more severe acidosis.
So if you lose bicarbonate, also you will have acidosis. What is the difference if you have lost 70 millimoles of bicarbonate or you have gained 70 millimoles of proton? You have got the same amount of acidosis. So why you are right that distal RTA is more severe, but the answer is not that. Do you think again?
That body is compensating by secreting more HIM.
So if you have a bicarbonate loss, it will only happen if you are filtering bicarbonate. If suppose your levels are so low you're not even filtering, you will not have further acidosis. So beyond a particular level, in an individual who has got a proximal RTA, you will have a self-limiting mechanism, which basically would mean that in that scenario, you will have a urine which will become acidic. So at a particular level, the proximal RTA becomes self-limiting, and therefore the extent or severity of metabolic acidosis in proximal RTA, typically bicarb is around 16, 17, while in distal RTA, we can go up to 10, 12 also. The severity is much more from that regards. So 99% of this is absorbed, 90% in the proximal tubule. So when we say proximal RTA, we are talking about problems in bicarbonate excretion, which is happening more. When we talk about distal RTA, we are saying problems in excreting acid, which is the exclusive work of the distal tubule from that perspective. So now let's go one by one. What about bicarbonate handling? I've already said that around 70 millimole per kg per day is the amount of bicarbonate which is filtered, and a vast majority of it is absorbed in the proximal tubule. And the process again is the same: carbonic anhydrase and the sodium bicarbonate transporter, which is going to take this along. This will be like 90%. Out of this remaining amount, you will have further resorption which will happen subsequently. Now, proximal tubule is not only the site for absorption of bicarbonate, this is also a site for absorption of phosphate, amino acids, and glucose. So if you have a proximal tubular dysfunction, it's very rare to have isolated RTA. You will also have glucoseuria, amino acid uria, and phosphaturia. This explains three things. One, you will have a much higher propensity of an earlier onset bone disease in proximal RTA because you're losing phosphorus. So it behaves, quote unquote, as a hypophosphatemic rickets in addition. Rickets or metabolic bone disease in distal RTA is largely due to acidosis. Rickets in proximal RTA is largely due to phosphorus loss, plus there is a component of this thing which is happening in that regards. You will also have glucoseuria. So a urine routine microscopy may be a clear-cut pointer towards the diagnosis of proximal RTA, and that is something which is extremely important, as would be amino acid uria. Now, I have often seen confusion in terms of diagnosis of proximal RTA. Distal RTA is difficult to miss. You may have severe bony deformities, you may have fractures which are there, you may have hypokalemic paralysis. So this is something which is, if it's severe, it's easy to detect. But proximal RTA, the acidosis is mild. Many times you will find that the report is absolutely normal. So when you have a high index of suspicion for proximal RTA, that is, you have a child who has got bony deformities, who has got rickets, he is 1 to 2 years of age, he may have had a fracture, you find a hepatomegaly, you find an eye sign, and your blood gas is normal. Look at other subtle clues. Look at urine glucose, and urine glucose may actually be positive. Look at the other parameters and particularly repeat the blood gas on multiple occasions, and then you will see mild acidosis, maybe around 0.5 base excess is going around -6, -7, and that could be a proximal RTA. So that becomes important. So surrogate markers are very important in the setting of proximal RTA. Now, the remaining 10% of bicarbonate, large proportion is again absorbed at the level of distal tubule, and only a small amount of bicarbonate is actually then excreted. That's like 1% of the entire amount of bicarbonate. So, as discussed, only 0.07 millimole per kg per day is what you're losing. You're putting in 70 millimole, out of which only 1% is being lost from that regards. Now, proton handling is important. All the proton that you see in the urine is coming from the distal tubule. All the potassium you see in the urine is coming from blood. Yes. So whatever potassium is actually filtered is reabsorbed in the proximal tubule. So the only potassium you see in the urine is coming from the same place, distal tubule, in exchange to the sodium. So all the proton which is coming here, because proton is not going to be filtered. It's going to be very acidic. Your urine will become very, very difficult to handle. So now proton, as I said, 1 millimole per kg per day, and this has to be pushed in actively using the proton ATPase and proton potassium ATPase. So this proton is actively pumped inside the tubule. Now, if the proton is there, it is very slippery. It is again going to go back into the body. So this proton from there is, because the gradient is there, you've got a gradient of 1 into 250, it's going to diffuse back. So to avoid this back diffusion, what do? So you produce ammonia. So if you have you been ever to a marriage party or something, barat sort of a thing, and they stop somewhere, and it's very difficult to get people back. People are roaming here and around. The same way the proton is very slippery. So you need to get people, bouncers, to get them back to the bus so that they go around. So for that, you get something like ammonia, which is a bulky product, which is then going to take this proton along in the form of ammonia. And this is how this proton is going to excrete. So you need to remember that all the proton which is coming in the urine is coming only in the distal tubule. And if you do not make ammonia, it's going to back diffuse. So the problem of RTA will happen if either this proton ATPase, proton potassium ATPase is not working, or this ammonium production is defective. In both ways, this proton is going to go back from that regards. So what it means also is that this ammonium production is a marker of distal renal acidification. And how do you measure this ammonium? Yes. So this ammonium is basically the positive one. So the urinary anion gap suggests that if your urinary anion gap is positive, it basically means that the ammonium production is less. This is RTA. If urinary anion gap is negative, which is the normal response in the setting of a hyperchloremic metabolic acidosis, that suggests a diarrhea or a gastrointestinal loss. So this is how the ammonium works from that regards, and then you're losing around 1 millimole per kg per day. Production is 1 millimole per kg per day, and then 1 millimole per kg per day is what you are excreting. So this is a balance which is being achieved. What does it mean in terms of the treatment doses for proximal and distal RTA? Of how much bicarbonate is required to treat them?
The reticular acidosis, there is loss of bicarbonate. So the bicarbonate loss is much more in comparison to the distal tubule. So in the proximal tubule, the bicarbonate requirement is much more.
So
higher.
proximal RTA, you will need more bicarb. And the problem is, if you give more bicarb, you will lose more bicarb. Remember hypophosphatemic rickets. Your phosphorus goes up, it goes in the urine. So as soon as your bicarb goes above 15, 16, 17, you start losing. So then the end game is very difficult. So you want to keep it not too high, maybe 18, 20 is fine. In distal, you typically will require lesser amount of bicarbonate, with an exception of somebody who has a long-standing distal RTA. So in the initial phase, you may need to give them a higher dose of bicarbonate, and then gradually the requirements will come down from that regards. Now, potassium, since we've talked about potassium, and potassium is extremely important from the perspective of pathophysiology and management of RTA, we need to understand that potassium is also freely filtered. So as I said, proton is not filtered, but potassium is filtered, but all of this potassium goes back into the lumen, out of the lumen again. So you've got 0 potassium at the distal tubule, And then you have got the epithelial sodium chloride channel, which plays a very, very important role in potassium, proton, and other positive ion excretion. So what does this epithelial sodium chloride channel do? It basically takes in the sodium and then it takes in the chloride. But in the process, because the sodium goes out quickly and chloride goes out slowly, there is a electrochemical gradient which is created. So this lumen becomes negative. So this lumen becomes negative, and from there you have got a negative thing, which means the positive thing will come out. So in exchange of this sodium, effectively, you can say you have got entry of the positive ions like potassium, proton, calcium, magnesium. So a lot of the other things will come in. And now I told you that this ammonia is responsible for taking the proton out. If your ammonia is less, the proton will not go out. So now consider potassium and proton are antagonistic to each other. So if you have hyperkalemia, what would the body want to do?
Hyperkalemia, sir, will be attention of.
Yeah. So hyperkalemia, what will you prefer? So suppose you have to decide whether I want to excrete potassium or proton. You can't excrete both, because for every one sodium, you can send either one potassium or you can send one proton. You have got a lot of hyperkalemia. So if you have to decide, what will you decide? Which one is better to go out? So you want potassium to go out. So your proton will stay in. So you will have mild acidosis. Anybody who has hyperkalemia will have metabolic acidosis. The other way around, if you have acidosis, body will excrete the proton, potassium stays, will develop a hyperkalemia. So hyperkalemia goes with acidosis, hypokalemia goes with, if you have hypokalemia with acidosis, what does it mean? Acidosis. So RTA, GI loss, or other possibility could be there. If you have hyperkalemia with alkalosis, what does it mean? Dhwani? So then why is there alkalosis? So that's a very, very rare scenario. Anything else you can think of? Unless you're using some drugs which are causing both, like a combination of spironolactone with furosemide. So that sort of a scenario can rarely result in that, but otherwise this is a very, very rare. Even hypokalemia with acidosis, only 3 causes, or I can say 4 causes. RTA, gastrointestinal loss, ureterosigmoidostomy, and acetazolamide, which is a carbonic anhydrase inhibitor, which basically is a RTA in that regard. Yeah. So this is something to understand. If you understand that, that becomes much easier. So if your potassium is going up, ammonia will come down. Hyperkalemia inhibits ammonia production. So your ammonium will come down in that regards. Now, how does this all interplay? If anybody has got acidosis, if you have an intracellular acidosis, your potassium will basically go out. And basically you will like to excrete potassium. So if you have high acidosis, as I said, you will have hypokalemia. Intracellular acidosis causes hypokalemia. So that is the normal response in the setting of distal RTA. While in proximal RTA, the response is different. Now, in scenarios where you have a sodium load or you have a RAS axis, which is more acting, you will get a greater function of the epithelial sodium chloride channel. So you will lose potassium and you will develop hypokalemia. So if you treat proximal RTA using soda bicarbonate, what are you doing? You are basically increasing the amount of sodium delivery which is there, and that will allow more potassium to come out, and that could be a problem. So what happens with acidosis? So if anybody has acidosis, basically you expect that bicarb should be completely absorbed. Anybody who has concentrated blood should have a dilute urine. So if you have a sodium more than 146, urinary osmolality should be more than 600. Anybody who has got acidosis has got no business to have a alkaline. What do you expect? Urine should be completely acidic. It should not be alkaline in that regards. So you should have no bicarbonate in the urine. your ammonia production should be more. So your NH4 plus in the urine should be more. That's why you will have a urinary anion gap and you expect a urine to be acidic. Acidic blood, acidic urine. Acidic blood, alkaline urine means, so it's distal RTA basically. So that becomes important from that perspective. Now potassium should also be lost, and that's important.